And today we are going to introduce basically two new elements, the plane finder and the face hunter. So the concept of the plane finder revolves around a concept of the natural head position. And this concept was introduced in the field of orthodontics in late 1950 by Dr. Maurice, who was a very well-known orthodontist out of the University of Harvard. And he states that the natural head position is a standardized and reproducible position of the head with the eyes focused on the distance. And therefore, the main purpose of the plane finder is to establish this standardized and reproducible position of the patient's head in order to reproduce the ideal planes of occlusion. So when we refer to planes of occlusion, we need to look at the major reference planes that we are using in dentistry. And these planes are the Frankfurt, the plane of Fox, the Camper plane, and the ala tragus plane. So the Frankfurt plane, well, this is the horizontal plane that represents the horizon, and it's the reference that we keep in consideration when we evaluate the natural head position. The Frankfurt plane is the plane that runs from the suborbital to the meatus acousticus, and the Camper and the ala tragus plane run from the nasal spine to the meatus acousticus. The plane of Fox is the plane of the horizon. It's a plane that runs parallel to the horizon. So the Camper and the ala tragus planes are the two planes that basically run parallel to the plane of occlusion. And when intersecting the horizontal plane, therefore the plane 0 forms an angle or a pitch. That is basically what we are evaluating when we mount our models into an articulator. And this pitch can differ from a plus 14 degrees to a minus 10 degrees, and certainly from person to person. So it's absolutely fundamental that we somehow need to locate this plane of occlusion through the ala tragus and the natural head position. So the Camper versus the ala tragus, many believe that they are exactly the same, and I'm one of those. The only thing that I can realize that differs in the fact that the Camper plane is a plane known to be a bony reference, therefore located directly on the bone of a patient. Pretty difficult to locate and to utilize and to visualize. Instead, the ala tragus is a plane that is known to be a skinny reference, therefore located directly on the skin of the patient. Much easier to localize, much easier to use, and much easier to see. So it's actually the ala tragus plane that has been adapted by the plane finder in order to locate the angle of the plane of occlusion. So let's take a look at the actual workflow in relation to the plane finder. Well, first of all, it's a device composed by a base stand on which a vertical plane is connected, and an horizontal plane, which is our plane of Fox or our plane 0, or the plane of horizon, and a mirror, and what we call the reference slots. These are the basic components of the plane finder, and the specific reason is to be able to find the natural head position or to determine the natural head position of the patient. So the patient, by looking directly into the mirror, into the horizon, is able to focus and create an ideal posture of the body itself and the head. And between those slots, we will locate two points, two dots, which are going to be our reference points. And the patient will walk up to the plane finder 2 or 3 times in order so we have the opportunity to verify that these markers fall constantly in the same position. This is determining the stabilized and a reproducible position of the head. Once it has been established, we will then fix it by means of some bite material and transfer this information into a physical articulator. So basically, it's a physical procedure in mounting the models in an articulator. So we do determine the actual midline by locating the midline seam on the model. We need to know the distance between the first molar to the hinge ax, and as we mentioned this last time, it is 90 millimeters. And then by means of this plexiglass, which we are able to line up the midline and the horizontal line to the center of rotation, bring this information into an articulator and basically fix it with a bit of gypsum and block it right into the articulator itself. So it's a manual transfer of the natural head position, therefore the plane of occlusion, the ideal plane of occlusion, directly into a physical articulator. This information can then be digitalized and brought through and executed through a digital procedure with the digital systems that are available today. The face hunter, instead, by introducing the face hunter, we are actually digitalizing this procedure. And the face hunter is a 3D scanner device by means of which we capture a series of images, of photographs necessary to mount into an articulator, and a series of images that will relate to the aesthetics. So by means of these images, we are going to capture the natural head position and locate the angle of the plane of occlusion, which we will detect by means of the ala tragus directly on the patient's face, and bring all this information directly into a digital articulator. So the whole procedure is basically digitalized. The first part is exactly the same as the manual procedure, where the patient walks up to the device, looks directly into the mirror. We will locate the 2 points in the reference slots. We will confirm this by proceeding by going through this procedure a couple of times. Once it's stable and we are sure that this is the natural head position, we are going to fix this position by taking a photograph by means of the face hunter. And we are capturing the natural head position of the patient, and certainly those digital markers that will be our reference necessary to mount the models directly into the articulator during the matching procedure. The second important phase is the face model alignment. We create this by utilizing what is called the face transfer fork. It is the only procedure that is invasive on the patient, and basically capture a bite or the position of the maxilla by means of that bite material with exposure of the digital markers. And again, this is then it's taken a picture by means of the face hunter in order to capture those markers, which will be necessary during the matching process to align the model directly into the patient's face. And then we can proceed by just taking all the aesthetic photographs necessary for the aesthetic evaluation of the patient itself. So the first most important is creating a 3D image of the patient. Therefore, a straight photo, a 45-degree left, where we have the opportunity to visualize the actual tragus of the patient, a 45-degree right with the same necessities. These three images are matched together or merged together, and they'll create a single front face, mouth closed image that we will use for the mount in the articulator. And then from here onwards, we can take all those images that relate to aesthetic purposes. So the smile, the mouth open, the mouth closed, all the phonetic photos that we would like to take. Once completed the series, these images are then all matched together. And we can move forward by mounting the models virtually in the articulator. So such as in the analog world, we need to determine the midline of this maxilla, and we do it by locating the midline seam. So by placing 2 dots directly on the midline seam determines the midline. The distance to the center of rotation, always in the area of the first molar. So we detect these 2 points, and automatically the model will just move into the articulator according these 2 elements that we have just set. The next step is to align the face to the model, and we'll do that by taking the face transfer fork or the impression of that face transfer fork and scanning it directly on a benchtop scanner, to which we will then match our actual physical model. And the physical model is matched to the impression. The markers are then matched to the face hunter images in relation to the markers, and this is a way of aligning the model directly into the patient's face. And then we will do a sort of a live demonstration and make sure that we get a better understanding of how all this procedure works. And the third element is the natural head position, where we take in consideration the image taken with the plane finder and its references. These images are matched to our digital plane finder that is into the system, and it aligns the face directly into the articulator. The fourth element that we do need to keep in consideration is the actual pitch, and this pitch is located by the ala tragus. So by determining the ala tragus, we automatically find the actual plane of occlusion. It relates to the tragus itself, and all the elements position themselves into the articulator based on these coordinates that we have just settled forth. The fifth element is the fact that the whole mount has been done digitally, and we would like to transfer this information directly to a physical articulator. So the system gives us the opportunity to create an imprint or a bite of the position of the upper jaw and transfer this information. This gets milled out in a milling machine. It takes around about 10 minutes, and then it's transferred over to the physical articulator, where the model is then positioned and fixed in position with a little bit of gypsum, and then certainly the lower is mounted to that. So it's a way of transferring the digital part of the mount to an actual physical part of the mount, and now we'll have the 2 elements in the exact same position. We are now going to move forward and try and put all these things together in a sort of a live demonstration, but it's going to start just after the video. Right. Are we back on track? We're back on track and back into our gypsum room in our scan software where we left off the last time. We have our two models mounted into the articulator. Last time we did mount them by utilizing standard data, and today we are going to add the elements that will custom the actual mount into the articulator. So we enter our scan actions. We go ahead and we import what is the face scanner raw data. I have it located in here. Where is it? Here. And it's under this guy over here. And it is the face scan raw data. I will select the folder and we will integrate and download the data. So after taking all these pictures by means of the face hunter, we bring them into the workflow. We download them into the workflow within the scan software. And at this point, we are going to go through the matching procedure. The first step is to locate. So here we have the 45-degree left, the 45-degree right. We have the middle picture. We have the center picture. A couple of pictures that relate to the statics, the smiles, the open mouth, the semi-half smile, and all those that you believe are going to be necessary for your specific aesthetic evaluation. But we're not going to focus on the aesthetics today. Today we are focusing mainly on the mount in the articulator and the major images that interest us in performing the mount in the articulator. So the goal is to create a 3D image, which we'll bring over to the right-hand side. It's always recommended to clean it a little bit, just in order for us not to have too much calculations. What we don't need is really worthwhile just eliminating it from the image itself. And to this 45, to this straight image, we are going to merge the 45 degrees. So we go to the left side, we seek for the image. This one here is the one I need. We can go ahead and clean it. And now we are going to match it to the image on the right-hand side. By shift and left clicking, we can actually highlight the areas where we would like the computer to focus and to concentrate. The matching process, we usually choose the forehead. It's the area which has less possibilities of variation. And by connecting two dots in that area, the image shifts over and it basically matches. We check it out by seeing if there's any overexposure of the image itself. And we usually check out that the design of the nose falls perfectly in position. So we can say that this image here has matched very, very well. We'll go look for the second 45-degree left, clean it out, and move forward with the shift. We need to take the minus away, left click, and we can highlight the area where we would like the matching to focus. And again, dot on the left side, left side, and right side, and the image moves in and we get it matched. Take a look and we see that there's no overexposures of the images. I'm pretty happy with what I have. Don't worry too much about the color. This is just the relation of how the photos were taken. We do need to focus on the fact that the images need to be proportioned between them. And the vision that we have is pretty comfortable to reality. Once we've performed the matching of the three images, it's called a complete, center, left, and right, and it is a mouth closed. So automatically the computer by selecting these elements, we'll name the file. We'll say OK. And at this point, we need to define an orientation. The skull has got nothing to do with this patient. It's just there telling us which is the front and which is the back. And this is what we need to tell the computer. This is the front part of this patient. Doesn't really matter where you put the dots, but now we have the orientation. The computer now knows that this is the front part and this is the back part of the patient's head. We can continue and carry on all the matching and saving of the file. So as we said today, we're not going to deal with aesthetics, but I need another two very important elements to bring into my workflow. I need for sure the phase transfer fork. This is going to align my model. So I will save this photo as a front, and I am going to name it FTF. That stands for the phase transfer fork. Say OK. And again, it wants me to align it or to match it to the existing image that I have already created. So the skull is not there anymore. The actual image appears. Shift, left click. I can highlight the areas that I want to focus the matching on. And again, dot, 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 dot. And the matching here turns to be pretty nice. We usually focus and concentrate on the forehead area. This is the area where we know that there's basically no distortion during any type of movement of the patient. And the third one that we are going to match is the plane finder, therefore the natural head position. Once we select this image, automatically the computer recognizes it as or a plane finder or the phase transfer fork. We are selecting the plane finder because this is what it is. The markers are highlighted. We shift and match. Again, we look at the area of the forehead. This is matched pretty well. We can take it down from the bottom and see that more or less it is aligning with what we had while we were taking these pictures. And we are going to utilize 2 or 3 of these images that we've taken just to have an average of every time the patient walked up and walked out from the position in the plane finder. And the computer will generate an actual average between every time we took the image. So again, we highlight, we match, and we're good. And we can do one more. Plane finder. I'm not highlighting, I'm just matching, just to see if it works. Yes, it's not bad. We're good with all these elements. I have the 3 basic images, photos necessary to perform the actual mount on the articulator. If the case was going through an aesthetic procedure, I would add all the others as well, but today I'm not really interested in that. Or maybe the only one that I will bring in is the smile, so I can evaluate and determine the midline. So we bring in the smile. We will save this. What is it? It's the front smile. Computer names it, and we say OK, and now we are going to match it. I'm not going to consider this as an actual functional image that I use for the mount in the articulator. This is just a reference that I'm going to use in relation to the midline and confirm that our case has been mounted correctly. At this point, I'm happy with what I have. I have everything that I need. We can go ahead and break the sequence, and you can see it on the left-hand side that the computer is generating all these images, and it will calculate them all, and they will all appear directly into our workflow. It just gives us a couple of minutes. Here they come. And there they are. They're loaded. They are all in our workflow. So let's just take a look at them quickly. I'm going to take these away and we'll just have a look at the face. So we brought in the matched image of the three together, and we have created an actual 3D image of the patient. So we have the opportunity now to visualize the ala and the tragus, and that's going to be the plane that we will be utilizing to determine the ala tragus. We have the face transfer fork. We have the plane finder, 1, 2, 3, and we have the smile. These are the images we brought into our workflow, and we will utilize these images to verify that our mount is performed correctly. There's one more image that I need to bring into the workflow itself. This is the actual physical face transfer fork, the one that we saw during the slideshow presentation that needs to be scanned on a physical scanner. So I will be importing that as a mesh. And I will find it here. And I'm bringing it in as the green fork with the model already in position. So this is my FTF, and we say, okay, an upper jaw, and it's going to load my FTF. I scanned the face transfer fork in my laboratory scanner, on my benchtop scanner, with the model already in position, already with the impression. So besides utilizing the anterior markers, I'm also going to verify that it matches and it combines with the actual model directly on the impression that we are going to utilize. Now, you see that the face transfer fork is somewhere around on the screen, the face images themselves are somewhere around on the screen, and the models are somewhere around on the screen. And now we need to bring all these elements together. And I usually start off by matching my face transfer fork to the actual physical model. So we go to the matching procedure. I'm going to move the face transfer fork to my model. So you right click the face by left clicking on the model that you want to move, it'll turn red. And by right clicking on the model you want it to stand still, to stay static, it'll turn pink. We go continue. And at this point, we can actually match the models together. So we choose a couple of points. I'm going to choose one here, and one here, and one here. And you can actually see that the matching is really very, very well done. So now we're pretty sure that the model is in the ideal position with the bite fork. And the second is going to be able to match this to the actual face. So we say apply. And now I am going to actually bring the face into this equation. So just remember the face is floating around here somewhere. I'm going to choose the face transfer fork. This face transfer fork is going to be my reference, and I'm going to match it to the face, to the actual physical face transfer fork. Therefore, activate my matching procedure, right-click on the element I want it to stay static, and right-click on all the elements I want to move. I'm selecting a group matching because I'm going to move more than one element at a time. So I'm going to move the whole face, all the face images that I had. So that's 1, 2, 3, 4, 5, and 6. These are all the elements I want them to move together in that exact position. So we go ahead and we say, okay. They all pop up on one side. And I am going to go ahead, highlight the area I want to focus the matching on. Locate the spots. I'm going to dot a spot here, a dot here, and I'm going to use this small one down here. And let's see what happens. Wow. as you look, as you can see, the matching on this element is really very, very well done. There's a good salt and pepper throughout the whole surface of these references. So I'm pretty confident that the matching now has been done accurately. I applied, and what we did here now is we actually brought the models into the patient's face. We can take these elements away that we don't need anymore, and we can verify that all the elements now are in position. What we have done here, we've brought all the elements together, but we haven't got them mounted in the articulator yet. So we are going to go through the procedure and taking all these elements together and basically go through the mount in the articulator itself. So we have a function that's called the cast mount, and we will activate it. By activating the cast mount, it gives us, first of all, the opportunity to choose any specific articulator that we are using. We are going to carry on using the PS1 articulator, but you can choose any one of those that is basically in your cabinet. We can mount it by means of using the face, which we're not going to work with today, or we mount it with the plane finder, and the last time we mounted the models utilizing the manual function. Today we are going to use the function that relates to the plane finder itself. So it's the digital way of mounting models into the articulator. It's asking us to detect the midline seam, so we will detect the midline seam. I believe that I'm finding it pretty confident to place it over here. It wants to know the distance from the center of occlusion to the center of rotation, and we know that in the articulator is 90 millimeters. So this is the first mount within these two elements. So if I just bring up my articulator, you can see that we have already placed it in the articulator. But we still need to determine the pitch, or the accurate pitch, or the exact pitch, or better again, the custom pitch of that specific patient. So what are we going to use for that? We are going to use the actual face. By determining I lost the point. Let me start over again. Plane finder, just let me do this quickly. I lost the point. I was distracted and it went forward. There you are. And now I'm going to bring in my face. What's that? I'm going to mark my ala, my tragus, my ala, my tragus. And these are those three images of the plane finder that we had saved together. These the images over here, right? And it's telling us that the averages of the roll angle, that every time that the patient walked up and down into that plane finder, and you can look at them, they are very close to each other. One's a 0.44, one's a 0.42, 0.2 of a millimeter of difference. This is how accurate that plane finder can detect the actual natural head position. We can choose all three of them. And you see every time that we select one, the head is going to move in a specific position, right? This is the difference roll and the difference pitch that we had every time we took an image. Is basically difficult to actually visualize it by hand, but the sensibility of the computer gives us that opportunity. We can choose all three of them and say apply. What the computer will do is calculate an average of all three these images and coordinate the actual pitch of this patient. So here we are. If I take the plane of occlusion of the patient and I take my median plane, I can actually see that it falls exactly in the middle of the articulator. Let's bring it here and let me just take the plate away. Voila. It falls exactly in the middle of the articulator and right in the middle of the midline seam. My frontal plane, which I'm not going to use today, and my horizontal plane, which relates to the pitch. So what I can also do is just have a mechanical reference in relation to the plane of occlusion that I would like to use. So if I activate the actual plane of occlusion by going into my reference objects, I can left-click on the plane and I can activate it, and I can establish the plane of occlusion just like we did manually the first time we mounted it in the articulator. We can establish it, take it, bring it down, and evaluate if it actually runs parallel to the plane of occlusion. And here we go. So look at the accuracy within we are working. It is really a great reference to keep in consideration, because it really does run parallel to the plane of occlusion. It is also true that the left side is never the same, or was hardly the same as the right side. So we can integrate a new plane of occlusion, which is the plaster plane. I think we showed that last time as well, and have the opportunity to coordinate and elaborate this plane as well. The good thing about, whoops, do you really want to delete the object? No, I don't want to delete the object. The good thing about the plaster plane is that I can separate the left plane from the right plane of occlusion. I can place it. Line represents the 90 millimeters to the hinge axe. I bring it back into position, select the width and the diameter of the teeth. So we have our two central incisors need to go, and look on this ortho plane, because this is basically an ortho plane, the accuracy of where the molar falls. It's right on the 90 millimeters with the central incisor right in the position of the central incisor. And now if we want to determine the actual plane of occlusion, I keep in reference the lingual cusp of the molar, I keep in reference the canine, and I keep in reference the central incisor. And this plane is already set, and it is set to round about almost a 6 degrees. Same element on this side. I'm going to keep in consideration the molar, the canine, and the central incisor, and the second plane is at 4.9. So as you can see, the left and the right planes are hardly the same. And it actually happens very, very often. So it's also very important to be able to have these elements under control when we are actually doing a setum, or we're actually doing any type of rehabilitation that relates to fixed prosthesis, dentures, or any type of implant case. Being able to individualize the different angles of planes of occlusion, left to right, and believing this happens very, very often, is fundamental for the functional part of what we're doing, and sometimes certainly also for the aesthetic part of what we are doing. So I've set it up. I've coordinated all the planes necessary to execute any type of rehabilitation that I have in mind. The next thing I would like to go through is to show how we are going to transfer this information into a physical articulator. Well, there again, the guys that worked on these programs did an amazing job in finding these solutions, because they are really very important and they are fundamental. I'm one of those that works, yes, on the digital articulator. It makes my life easier, but the final execution or the final case is going to be checked anyway on a physical articulator. So I do have them always mounted digitally and then physically. It's really very, very important for me to have them both to my disposal. So here again, we show the jaw positioner, and we're just going to say, call it AAA today, it doesn't really matter how we name it. And the computer sets up our jaw positioner, which by left clicking, we activate the jaw. We are telling the computer basically to create an imprint. I'm just going to take it away a second so we can see what happens. And if we go to apply, it generates an imprint of the model in that exact same position. This byte transfer, that's how I like to call it, because it is a byte transfer or a maxilla jaw positioner. I will utilize it to transfer it directly into our physical articulator. So this gets mounted, and then as I showed you through the images earlier on, it is positioned on the plane, on the mounting plate, and fixed to the articulator. And then the lower is then fixed to the upper by means of the centric relation that we have to our disposal. So at this point, everything that relates to the mount is executed all in our scan software. We have all the information here. We bring everything up onto the screen because we want to save every single element that we have just set up onto the articulator, and we save this information. And once saved, we will open it up in our Modelier software. We always do that through the archive. I've already got it open, so we don't have to sit there and waste time for it to open. I'm happy with what I have. I'll activate my Modelier, and now I'll have all these elements active now in my design software. Okay, I'm just going to activate this one. So I have my face scans. I have my planes of occlusion, the ones that we have actually all set up. We have the jaws, the entire jaw, upper and lower. So all the elements that we need are actually here. Now to perform a functional evaluation, I don't really need the face, but I did utilize the face to mount in the articulator. This is fundamental. It's the whole scope of the plane finder is to determine the natural head position in order to find the ideal plane of occlusion, or the ideal angle of the plane of occlusion. So once we have determined that, we don't really need the face when we are performing functional evaluations. So we have our models, we have them activated, and at this point we can activate our beloved articulator. We open up the movements. It's not activating this morning. Let me see what's wrong with it. Activate movements. Why isn't it activating? Okay, let me bring it in from the beginning. I'm stalling. Let's go. And here we go. As usual, you coordinate your Bennett. And again, today we are going to use, actually this is the eminence. We're going to bring it to 30 degrees. Standard values, and then the next time that we will be setting up a case, we will be using, this is going to go to 15. Just a little bit of patience. Everything here is very small. I can barely see it. 15, perfect. Here we go to 15. Perfect. And here we go to 30. Straight down, one. Okay, good. I'm going to have a little bit of a longer movement. So I'm bringing it to 7 millimeters, the extension of the movement. This varies to how far you would like the movement to extend. Got it. And at this point, I can also bring the incisor plate down to 0. I'm not really interested in the incisor plate to perform any type of movement, so it goes down to 0. And now I want the computer to read the surface of my teeth, and off it goes. It just takes a while to calculate. Okay, now we have it active. So let's go ahead and take a look at all the elements, our stop centrics, our positioning, and we can start the first part of the movement. 1 millimeter, 2, 3, 4, 5, 6, 7, and it starts here. That's the first contact that we are going to find during the protrusive movement. So we do need to evaluate what we are going to perform on this protrusive movement and how we can diversify. So we take the lateral movement, which is 1. In the first millimeter, the canine actually moves out of position, loses its contact, and the contact persists on this molar. So it's 1, 2, 3, 4, 5, 6, 7, 9, 10, and it goes all the way until the canine captures that movement one more time. So what happens if we eliminate this contact and see how this canine is going to behave during this movement? I activate it. We go extra. We go modify scans. And we are going to perform an odontoplasty on that tooth and then analyze how the actual movement changes. Now, doing this in the analog world, it takes you to set up at least 3 or 4 models before understanding the correct trajectory of this movement. Here on the computer is certainly much easier, much quicker, and much faster. So I think it's just really a great way, and I'm enjoying it a lot, being able to perform all the functional analysis on the computer. Therefore, we're going to make our little brush very, very tiny. That's my first contact. It's my stop centric. So I'm leaving it as a stop. We lost the canine, and from here onwards, I am going to start eliminating a little bit of material. Carry on the movement. I find a little bit here. Carry on the movement. Whoops, maybe I took a little bit too much there. So it's just like eliminating very, very, very small quantities of tooth, of biological material in order to avoid this pre-contact on the not working side. So there's no contact on the molar and the canine starts over here. At this point, we need to repeat the movement in order for us to re-record it. So we go from the beginning. We say yes, and we repeat it. And now we'll see the trajectory, how it changes on the canine, or if this tooth is still carrying the load of the movement. Let's repeat it. Now, these are sometimes functions that we do in prosthetics as well, not only on natural dentition. This is where it starts, performing the functional evaluations on natural dentitions, but certainly it's more or less the same idea and the same techniques when we are working through through prosthetics. I think that maybe we will also have the opportunity to do a video in relation to some setup cases, so we will actually see them in function through the actual setups, how we move the teeth and how we relate to the angles in coordination to the movements that we need to perform. Here we go. So he's back. Let's take a look. I'm going to say okay. And let's see if something has improved. We go 1, less than before, 2. The canine is still carrying the contact. 3, it loses and the premotor starts taking the contact. So you see how the contacts change just by eliminating something down on the posterior area. Look at this. 1, 2. The premotor starts taking the contact. This contact was not there before. 5, 6, 7, 8. So basically what we've done here, we have increased the problem. Now we have to find a solution. And the solution is the same. We carry on working on that contact. Extras. Modify. It's a little bit slow today, the computer. Usually it clicks and it opens up immediately. Now it's doing a little bit of heavy calculation. I also wanted to see what happens on the other side when I add it on. Okay. Yeah, it's a little bit slow today. We need a little bit of patience. So let's go. 1. I'm going to make this smaller. Go 1 more. Seems like that this whole cusp needs to be the whole cusp, we need to change the angle. I think we're good. Let me check it out. Okay. Here we go. Go all the way. We are almost through. I'm just going to smooth it out quickly. Smooth point, something very, very small. Very, very low intensity. Let me check it out quickly. It goes all the way through. But now we know that we have a problem on this tooth as well, so we need to correct this angle here too. And okay, it could be that it's still touching just a little bit, but at the moment it's going all the way through. We say okay. And we need to reactivate the articulator. So let's say yes, and let's reactivate. So this is basically the procedure that we need to go through, step by step, tooth by tooth, evaluate where the contacts are, start eliminating them, and at the end evaluate how much biological material we need to eliminate in order to get a clear movement. If it's worthwhile taking away, if it's necessary to add, if it's something that we need really to evaluate and go through an ortho procedures and so on and so forth. So we are putting together all these elements to get a better understanding of you know, what direction we should actually be moving. And what happens if we do perform something? As you see, you might touch one pre-contact on a tooth, and 10 more will pop up on another side. So sometimes it's really worthwhile taking a look at everything, and sometimes it's just better just walking away. But with patience, we can really get a good understanding of how everything works. there again, we go 1, 2, it's only touching on the premolar, still holding up the load, and then it just touches something down there. So we still need to work a little bit on this premolar. Let's take it down. Let's take it down all the way, modify, scan. I'm really curious to see how that canine is going to take the load. So I'm going to go all the way to the end. Yeah, it's a little bit slow today. And if it's something that we don't do now, Mama Nature is going to do it slowly over time, just creating a huge trauma to the tooth itself. So sometimes it's really worthwhile evaluating these odontoplasty treatments. So let's see where we are standing. I'm coming over 1, 2, and it starts hitting. Let's take it away. I'm going to smooth it out. Now maybe I'm taking away a little bit too much. I'm a little bit in a hurry. If in reality I would take it a little bit easier. But I do understand that we have a limit of time, and I want to get to the end just to show you how it works. Okay, I think that there's nothing else that relates to that. The movement, there's still something here. I'm good with the movement. Perfect. Take it in, apply, and regenerate. So I hope that this time everything comes through, and we can move to the option where we are going to try and add material and see the result. Kia ora ti. Way over time. Okay. One more quick thing, and then we'll close it. We are just a little bit over time, but I did want to get to the 2 different options that I see that need to be performed in this evaluation, and are the ones that we usually keep in consideration when going through these evaluations. So we'll just go over time a little bit. Let's take a look now and see if we're good. Let's go. 1, 2, 3, 4. The canine is still not working, so that means that we're going to have to take it down a little bit more. 1, 2, 3, 4, 5, 6, 7. We need to take it down a little bit more. Starts on the 4th. Extras. I'm going to take away a little bit more than what I need. This is keeping in consideration the fact that we're not touching or moving that canine. The anatomy looks pretty good. There might be something that can be modified in relation to the position. If the odontoplasty is not an exaggeration, it can be performed. If it is an exaggeration, that means that we are going to take away too much biological material. Then we have to evaluate the fact of shifting the canine in order to get a better, a better side shift. We're going to have to take away a lot of material. So most probably an odontoplasty on this tooth is not going to work. But now we know that. So in the therapy, most probably we'll keep in consideration an ortho treatment. It's really a lot. Let me smooth it quickly. The whole cusp needs to change angle. I don't think we'll be able to do that with an odontoblasty. Most probably we're going to have to do it with an ortho treatment. So let's just go out and check what's going on. And this is the game. The game is to take material away, perform a movement. Yes. Repeat the procedure until we get a clear movement, and then evaluate how much material needs to be exported in order to get the ideal movement. This is all it is. A lot of patience and a little bit of time to evaluate. Let's just see for the last time on this tooth what goes on, because I believe we have more or less the same problem on the other side. But I was curious to evaluate the other canine that has a pretty heavy abrasion. If reconstructing that abrasion, we will reacquire the actual function on the tooth. Let's go and take a look. 1, 2, 3, 4. It's working. 5, 6, 7. Here it is. Now you get the function back on the canine. So that's more or less how much material you need to take away before we can get the function on the canine. Right, so we've got it back, and then we'll go through all the evaluations necessary. We have more or less the same problem on the other side. So if we hit it here, 1, 2, and you can see the molar, the second molar, the palatal cusp of the second molar starts taking the load. And I was just wondering if by adding what is actually missing here would improve this function. So again, we go ahead, we go extra, add and remove, we go to the modifying function, and here we can actually add what we need to, in order to verify if what is missing is the cause of that pre-contact on that molar. It's just taking a little bit of time, guys. Have a little bit of patience. Here we go. And now we can go through a function of add and remove. Right? We can see that here there's a little bit missing. I'm going to add it. That little corner that's missing. Smooth a little bit. Let's make it smaller. And let's see if this somehow helps. We have to apply. Sorry. I have to apply and then activate the articulator. Here we go, and activate. This can also all be performed in an ortho software where we can move these teeth around and get a better understanding. So once we go through the procedures and the evaluations of the odontoblasty, if it is in an exaggerated position, we can evaluate everything through an ortho program and understand how much this teeth needs to be moved in order for it to be able to perform the ideal movement. There you are. Let's just check it out quickly. And let's go. 1, 2, 3, 4. It still takes it. 5, 6, 7, 8. Yeah. We gained a millimeter and 2 millimeters. We gained 2 millimeters, so it could be that by eliminating 2 millimeters on this angle, extra, modify scans, I can rebring the function on that canine. Come on. And here we are. Shake this cusp a little bit. See if it takes any other movement. Seems like that it doesn't. I don't know if I've taken off enough. Apply. One more shot, and if it works, we have basically completed our testing. So here we go back in, and time is getting short, guys. I'm so sorry about that. It does take a little bit of time to perform these evaluations. It's not something that is done very easy, or digitally or physically. It takes a little bit of time. It could also be that my computer is just a little bit slow. I must probably need to take some stuff out of it in order to be a little bit faster. So just bear with me. But at the end, it's just important that we understand and we get a feeling of what it really means to perform some functional evaluations. I also do believe that it's the foundation on which helps us solve a lot of problems in the prosthetic world. So 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm on the K9, 10. Perfect. That's what we're looking for. Right, so now we have an idea of how much material. The exclusion is really 1 after the first millimeter, which is perfect. 2, 3, 4, 5, 6, 7, 9, 10, 11, and we go all the way to the tip of the canine. So by adding a little bit of material, we certainly help the fact of taking weight off this tooth. And then certainly, maybe I exaggerate a little bit. I would do this with a little bit of more patience in order to have a better understanding of how much material needs to be taken away. This could be a case that can solve very, very easy with a little bit of odontoplasty and just touching up a little bit of elements here and there and bringing back the ideal function. And that's basically what I need to say. And this is what I can say in relation to setting up the models in an articulator with custom values of the patient itself, keeping in consideration the natural head position, which is something that I do understand in prosthetics. We haven't been evaluating all that much, but it's a practice often used in ortho, and it's a good thing that we are able to evaluate this natural head position in prosto as well. So guys, thank you all very, very much.